first of all, a big thank you to the organizers. I think it's a great location, and I really appreciate the whole day so far. You mentioned it twice. It's dangerous to work with me because I'm going really into the detail. So this is probably out of the heart of a researcher, that you want to go into the detail and you want to understand why there are phenomena using complementary substances. And I actually want to introduce a research model we are talking about since probably 15 years now. And this is a patient-derived cancer spheroid model which I want to introduce. And I never thought that I would test complementary substances in this model. I'm actually coming from the traditional medicine. So we are talking about chemotherapy, targeted therapy, checkpoint inhibitors. But because of the pressure of our patients, and of course of the pressure of people like you, Reinhard, we actually had to test complementary substances. And for that reason, I actually want to show you first a little bit about this patient-derived cancer spheroid model, about the biology, about the clinical validation. And then I brought some brand new data about artesunate, which we will publish in the next months. Also what we get for results in this specific model. So when we're talking about spheroid models, then we are talking also about personalized medicine, precision oncology, in individual medicine. And if you go closer to the literature, you actually find a lot of different samples and different methods to stratify patients for the right treatment. So think about, in breast cancer, we are always ahead of all the other cancer types. And if you have a closer look there, you will find a lot of data about genomics and probably epigenomics. And it's not all about tissue, it's also all about liquid biopsies. It's about the newer stuff like histocultures, like bioprintings. So you see there's a lot of ongoing in personalized medicine to come closer to a good decision of treatments for the individual patient. And this is actually the goal which we follow up, and for that reason we developed this new diagnosticum, which is called patient-derived spheroid model. Now I have an old instrument. So how do we do that? When we are talking and developing this 3D microtumors or patient-derived spheroid model, which is the same, we always need fresh tumor tissue. Sorry. Yeah, we need fresh tumor tissue. So we can deal with biopsies, surgical tissue, or ascites, or other fluids containing tumor cells. And we need this fresh tissue, and we do right away the preparation of the 3D microtumors. So there is no interculture in between. And this helps to preserve all the original characteristics of the cancer cells. And we are not just interested in the cancer cells. We want to keep the microenvironment of the tumor. So we are talking also about the immune cells, the fibroblasts, the biochemical tumor microenvironment, like acidosis, like oxygenation. So preparation of the microtumors right away of the fresh tissue is done immediately as soon as possible. And then actually we treat the microtumors with all the treatments our oncologists are recommending. So this is not our decision which drugs are we testing on the microtumors. This is a decision of the people sending us the tissue, because you guys know your patients. You know about pretreatments. You know about complementary diseases. You know about problems of the patient. So for that reason, the decision maker is the oncologists or the therapists who are dealing with the patients. And then within 8 days, you get the reports, which is something like a hit list you get. And I will show you an example for that. So first about validation of the biology, because we want to come very close to the original tissue we prepare these 3D microtumors. And actually, I was quite shocked. The first paper we published for the microtumors was already in 2001. So we are busy since 22 years with this technology, with the biology and the clinical validation. Well, first of all, in addition to the 3D structure, which is mimicking the penetration barrier for the drugs, we have tumor differentiation. So we want to see glandular structures in a 3D microtumor if the original tissue also has a differentiated tumor architecture. The proliferation rate is very important. You know from breast cancer that a patient with a 10% proliferation rate are on a good side. By everything over 50% is on a bad side associated with poor prognosis. So we want to see that in the microtumor model too. And then we have this heterogeneity, and it's all about heterogeneity of cancer cells. They are not all the same. There is a big variety within the patient tumor and within the spheroids too. And the microenvironment I have already described with this acidosis, this central necrosis we have in bigger tumors. So we want to recapitulate that because all this microenvironment is also impacting the response to the drugs we are giving. And of course, we want to identify patients, they are drug resistant. So we have acquired drug resistance, we have intrinsic drug resistance, and we want to see that in the model too, because we want to do a good recommendation for our patients. So this was more or less a more than 10-year time frame to like show that there is a biology which is recapitulated from the patient tissue to the patient-derived spheroid model. But you know, you can develop models forever, but if there is no clinical value to them, who cares? So for that reason, we were pretty much forced like to go ahead and do our clinical predictivity trials. And actually, we started with a SPHERO-NEO trial, and this is something like 8 years ago that we finished the SPHERO-NEO trial in breast cancer patients. Then we started with a colorectal cancer trial. There we had as a primary readout progression-free survival, so that took much longer, and it was still published last year. And then for primary ovarian cancer, this is a SPHERO-ID trial. The paper is just submitted. And the trial, which is actually running continuously and where we like collect patients over patients every day. So please feel free to send your patients over, because in this trial we do not care about the cancer trial. We want to see the heterogeneity in this model between the pancreatic, the prostates, the brain tumors, to see if there are differences also in the composition, also in the reaction of the 3D microtumor model of treatments. And then my favorite trial, actually, where we are still busy, is the liver metastatic colorectal cancer trial. We are right now waiting for the go from the ethics committee, because we had to do an interim analysis, which is going on right now. So summarizing all the results of this clinical validation studies, you will see here. So please do not be shocked about all the statistics. I just mentioned the 3 trials we finished, published, submitted. Here we have the primary breast cancer in the neoadjuvant situation. Our primary endpoint was pathologic complete remission, so a very short time frame to get first results in 2015 about responsiveness in the clinic. And you see we have a sensitivity of 95.5% and a specificity 91.3%. The newer data are about the SPHERO-PCT trial, which was published middle of last year. Here we are busy with primary colorectal cancer in a very prognostic good situation, no distant metastasis, fully removal of the primary tumor. Here was PFS, progression-free survival time, which is in this very good prognostic situation, 5 years. We also reached the goal of predictivity with a sensitivity of 63 and a specificity of 86%. And the ovarian cancer trial, SPHERO-ID, we had the 5-year overall survival. So this was finished last year with the follow-up data. we also are predictive for the clinical response. And you all know it's a nightmare in primary ovarian cancer. These patients develop within 18 months relapse, even they got surgery and very heavy chemotherapy for 6 cycles. And the sensitivity is 82.9 and the specificity 87%. So you see, we have done our homework. We spend a lot of effort, something like 20 years, for biological and clinical validation, because we want to bring this model into the clinic. And as I mentioned before, because of the pressure of our patient, which is probably more high within the last 5 years, or I was in the wrong environment because it was just traditional medicine, we got more and more questions. Can you actually do complementary substances? Can you something like combine chemotherapy and complementary substances? And what we then did, this will be the next slide, we actually included in our testing of chemotherapies, hormone therapy, when you think about prostate and breast cancer patients, targeted therapies, which is shooting up probably since 7 to 10 years, where we get new targets, something like every month. We do the checkpoint inhibitors, think about the pembrolizumab, the nivolumabs, you give in colorectal cancer or lung cancers, and we do the complementary substances. So this is a list, actually, of complementary substances we are able to test, and there are something like, we cannot do everything. This is our biggest problem. We have strong recommendations that we test these substances. They have to be dissolved, because we are working in a preclinical model. These substances have to be pure, so no mixtures. And you heard from Dr. Rose in the morning that quality is a very important issue, and I completely agree with this, because there are so many complementary substances on the market. We have to take care that these substances are pure and that there is a peak plasma concentration. So there needs to be at least one clinical trial in a phase 1 that we have an idea about the dosing we have to put into in our spheroid model, and we have to test. Because sometimes there is a patient standing in the door with a capsule containing like 50 different ingredients, asking for testing. So what should I do with this, right? It's not pure, there's no PPC, so there will be no realistic information out of this. And what is very important, and this is what we discussed, which was, I was asking Reinhard this morning, we need the corresponding solvent control. So this means if I have a curcumin which is dissolved in colifor ELP, I want to have exactly this corresponding solvent control. I think I remember correct, Dr. Rose mentioned that he dissolves his curcumin in colifor ELP, ethanol, and citric acid. And exactly this combination I want to have in the corresponding solvent controls we always use as a correspondence and side-by-side comparison. So if you go critical to the literature and you have a look at the papers published about curcumin, 99% of that are based on DMSO solvent. So they buy by Sigma or other chemical distributors. They dissolve the powder in DMSO, which has nothing to do with the complementary substances you inject into your patient. So for that reason, all this pharmacy producing the solvent controls for us, a big thank you, because we need this for like a realistic comparison. What is solvent control effect and what is substance effect? So you have seen a lot of substances we can test in side-by-side with like traditional guideline recommended treatments. And what I brought today is the artesunate data. Artesunate data will be published next month. And from these data, I brought some of the results. So first of all, we have 39 patients which we had treatment in the patient-derived microtumor model. And here you see the results of these 39 microtumors. We tested for artesunate, and in comparison, in the same 39 microtumors, we did the recommended chemotherapeutic drugs, a single agent, double agent, and triple agents. So think about, for example, a colorectal cancer patient. We tested 5-FU, which is recommended in the guideline, 5-FU oxaliplatin, which is recommended in the guideline. And if you have a fit younger patient, you will find 5-FU oxaliplatin combined with irinotecan, also recommended by the guideline. And you see, because the own fair comparison is artesunate as a single agent in comparison to chemotherapy as a single agent, we have a significant difference, and the chemotherapy is slightly better, and this p-value is 0.02. 0.05 is like the maximum. So this means artesunate as a single agent is not as bad in comparison to a chemotherapy as a single agent. If you have a closer look to peripheral blood cells, and we are not talking about liquid biopsy, thinking about the cancer cells, here we have like a focus on the immune cells, because a lot of our patients are asking, can we do complementary substances to make the immune system fit for chemotherapy? And so the hope was that we can stimulate the immune system by artesunate or other complementary substances. But you see, there's limited stimulation. There are some patients, we get a nice effect on the immune system, but usually it's low. So you see, the question is now, how actually can we improve this artesunate effect, use a single agent? And for that reason, we did combination therapy, also with chemotherapeutics. And here you get some individual results, because it's all about our individual cancer patients. We are talking about personalized therapy. Here you have a cancer patient with recurrent glioblastoma. Recurrent glioblastoma, you have TEM usually as the guideline recommended drug, but this patient has already seen 3 or 4 different treatments before, so you see there's a certain level of drug resistance. Temozolomide alone was not so good, artesunate alone was not as good, but if you do the combination of both, you have chemosensitizing effect. So I think this is like good news, that we can not only use complementary substances directly as single agents, but we can use them as chemosensitizers. And if you go deeper in the literature, you also have the possibility to do radiosensitization if you combine radiotherapy with complementary substances. But you have to be careful, because this is not always the case. And now we are back to individualized testing. So patient number 6, this is a primary ovarian cancer patient. And in primary ovarian cancer, you usually use carboplatinum combined with paclitaxel as a first-line treatment. You see lousy effect. I mentioned earlier that 80% of our patients develop within 18 months relapse. So no wonder that you have not the 90% response, carboplatin, paclitaxel. Artesunate is a low inhibition, and if you combine the both, you have a chemo reduction. So this means, and this is what I was asking you, how you combine your drugs without knowing if curcumin and artesunate actually, or resveratrol, whatever you are combining, do you know that ahead? If you get chemosensitizing, no effect, or even chemo reduction, because this would be really counterproductive. And actually, 2 weeks ago, we got a young breast cancer patient. First diagnosis was 2017, and nowadays she has ascites, and we have to take out the ascites every second day, 6 liters. So we went back to the classical chemotherapy and figured out that 5-FU, treosulfan, and epirubicin, all of them as single agent, are still okay in responsiveness on these ascites spheroids. And from other complementary substances, this was artesunate, single agent artesunate combined with resveratrol, also very inhibitive, and curcumin followed by vitamin C. And now the question is, and the results will be ready Monday evening, which of these 3 traditional single agent, 5-FU, treosulfan, and epirubicin, are in interaction with artesunate curcumin and vitamin C? Do we have like an improvement of chemotherapy, or are we doing chemo reduction? And I think these are very interesting questions, like to figure out the best treatment for the individual patient. Take-home message, use a good model and do it before you treat your patient. Test all the possibilities available from the guideline or also from the complementary medicine. We have to do the prospective trials, and for that reason we are really keen on the interventional trial. Can we confirm the predictivity trials also in an interventional trial? We do not just consider chemotherapeutics and immunotherapeutics and targeted therapies, because I think our patients are right. We have to consider natural products, but you know the traditional medicine is still very preserved about natural substances. And I think we have to consider not only the most effective, but also the optimal treatment. So thinking about side effect, we have heard about pain release and how we can stop this. And I think an important issue, even you have a fully pre-treated patient, which is like fully drug resistant, what can we do with natural substances? And I actually have finished at that point, happy to take questions. And I want to use this forum question which is bothering us every day in the lab. We see these effects of the natural substances, but it's in comparison to traditional drugs, very lower. So the question is, how actually can we improve the efficacy of the natural substances in the present case artesunate? Because you have seen we have a range between minus 16%, which means slight stimulation of the tumor, up to 56% inhibition of a tumor, which is really good. And we have 4 patients, the artesunate treatment was better than all the traditional chemotherapeutics we tested in comparison. We have 15 patients where artesunate was equal effective like traditional chemotherapeutics. And the question is, how can we improve the others? By combination. So we were discussing with Dr. Rose the ferro substitution, probably with artesunate, and I would like to hear about your experience. How do you combine artesunate in your patients to get good effects? So probably we can go ahead with this testing and then already consider your suggestions how to improve artesunate as a double or triple or whatever therapy. Thank you.
Es gibt keine Patienten, es gibt keine Therapeuten, es gibt nur Menschen.